Good morning, everyone. Welcome to the SGH Rheum Rapid Review Series lecture. Today, we'll be covering the topic on falls in patients with rheumatological diseases. I'm Dr. Rachel Ng, Associate Consultant of the Department of Geriatric Medicine at SGH, and my fellow colleague, Dr. Tan Zichin, Consultant of the Department of Rheumatology and Immunology from SGH. We'll be taking you through this. Let's start with the learning objectives. To appreciate the importance and impact of falls in patients with rheumatological diseases, to appreciate the importance of maintaining postural control in fall prevention, to know the risk factors for falls in this group of patients with rheumatological diseases, to know how to assess patients with falls, and to individualize multifactorial interventions for fall prevention. And lastly, to be aware of fall prevention measures available in the hospital. Based on the learning objectives, we'll be covering the following topics: the definition and consequences of falls, to understand what is required for the maintenance of postural control, to review the common risk factors for falls, and learn how to assess a patient with falls based on the multifactorial fall risk assessment tool. Lastly, to look into the multifactorial interventions that is best delivered through an interdisciplinary team approach, and going through the case scenario to better understand how to assess a patient who sustains a falls during hospitalization. Now, to better understand falls in patients with rheumatological disease, we first need to define fall. A fall is defined as an event which results in a person coming to rest unintentionally on the ground or lower level, not due to an acute event, nor due to an overwhelming external force to which any person would be susceptible. Let's look at the consequences of falls. Falls increases the risk of future falls. It also results in a fear of falling, resulting in also injuries such as hip fractures, rhabdomyolysis from long lie, if the individual is unable to get up after a fall, resulting in acute kidney injury, and also increases the risk of pressure injuries. It results in functional decline, disability, and inactivity. It poses high mortality and morbidity, increases the cost of service use as well, and it also results in a loss of autonomy from depression, loss of self-confidence, and loss of efficacy. Let's discuss more about the high service use and costs from the healthcare financing perspective. Something that we may not realize, and we should ask ourselves, what is the cost of falls? So 8% of elderly patients 70 years and above who visit the emergency department are actually there for falls. This is seen every year, about 8% every year. And 1/3 of these are being hospitalized. 5.3% of hospitalization among the 65-year-old and above are also due to falls. And based on the US data, the cost estimate is about 20 billion in the year 2000, and in 2010, about 32.4 billion. Falls also precipitate nursing home entry as well. What about in Singapore? So in Singapore, 13.9% of the elderly 65 years and above among those who visit the ED are actually 13.9% are actually there for falls. Half of these were actually hospitalized, and out of those hospitalized, 12% of them are actually due to falls. So the diagnosis among elderly fallers, about almost 20% sustained head injury, 11.8% sustained hip fractures, infection and pneumonia are also common diagnoses among these elderly patients. So why are falls so debilitating? It's debilitating because it involves a vicious cycle of falls, where repeated falls, as defined of 2 or more falls over the last 12 months, results in the fear of falling. And once this fear develops, it triggers the individual to refrain from mobilizing, hence reducing mobility, which have negative effects on our body's normal physiology, increases the medical problems such as pressure injuries, infection of the lungs and the urinary tract, and also with more medical problems resulting in social isolation and functional dependence and depression, giving rise to significant consequences of falls, as we have discussed earlier on, resulting in significant morbidity from reduced ability to perform activities of daily living, higher rates of readmission, longer hospital stay, and higher rates of institutionalization. Overall quality of life reduces as well, and mortality increases. So what then is required for maintenance of postural control that you and I have? That when we stand, we are able to stand upright and ambulate safely without falling. So the maintenance of postural control involves a complex integration of sensory information regarding the position of body relative to the surrounding and the ability to generate forces to control body movement with regards to the musculoskeletal system. So when we can better understand the environment that we are in based on our sensory system, we can create and trigger inputs into our brain for processing, and thereby advise us on compensatory outputs to generate such that the appropriate muscle, bone, and joints are activated to help us adapt well to our environment and to maintain this postural control. Of course, maintenance of adequate blood perfusion of the organs that contribute to optimal function of these sensory and musculoskeletal systems during postural change is just as important. This interactive feedback loop must have failed at some level for falls to occur. So let's now look at the causes of falls. So the causes of falls tend to be multifactorial, where it's dependent on the individual's risk factors, the activity and behavior, as well as the environment. And it's usually not observed. Many a times falls are unwitnessed. Though we need a good fall history to better determine the mechanism of falls in order to prevent future falls, but quite commonly the individual may have a poor recall of events. And there are actually different ways to characterize causes of falls. So common risk factors of falls are broadly categorized as predisposing factors as well as precipitating factors. So not all falls need to have a precipitating factor. If one has significant predisposing factors to falls, they may not need any precipitating factor because their ability to maintain postural control is poor due to the presence of these predisposing factors, which may be divided as intrinsic or extrinsic factors. Among the intrinsic factors, I would like to highlight the impaired vision, medical conditions such as postural hypertension, and of course, arthritis, and neurological conditions that contribute significantly to their risk of falls. For the extrinsic factors, I would like to highlight medications as one of the high risk factors that contributes to postural hypertension or hypotension and compromises the adequate perfusion to organs that's required to maintain the postural control. And also the lack of or inappropriate use of mobility aids or footwear are also important factors to consider. And of course, we have precipitating factors like risky behavior, dizziness, acute illness that can all precipitate a fall. So just to highlight the common risk factors for falls as seen in the next slide of the 16 studies, with arthritis as one of the top causes, which we'll be learning more about later. Though impaired gait and balance constitute a high risk of falls, so does impaired vision. And in fact, vision alone, vision itself also affects balance, in addition to proprioception and the impaired vestibular system. So moving on to how vision causes falls. These are the important visual functions where, if compromised, increases the risk of falls, such as visual acuity and visual fields that tend to be compromised in the following medical conditions of corneal degeneration, cataract, vitreous hemorrhage, diabetic retinopathy, macular degeneration, and glaucoma. In addition to that, contrast sensitivity, depth perception can also be reduced with age-associated physiological changes and dark adaptation as well. All in all, if the vision is, these visual functions are compromised, fall risk will definitely increase. Next, we move on to postural hypertension as a common cause of falls. So postural hypertension is defined as a drop of 20 mmHg or more of the systolic blood pressure, or a drop of 10 mmHg or more than 10 mmHg of diastolic blood pressure after 5 minutes of rest in the supine position and after 3 minutes of standing. It's fairly prevalent in our community. 6% of our elderly population have postural hypertension. Some may be asymptomatic, and 40% prevalence in hospitalized elderly. Most of the time, it's more pronounced in the mornings, but the patients are more dry. It causes significant symptoms ranging from dizziness, a woozy kind of sensation. Sometimes patients will say, "Tau pong pong," and dialect, breathlessness, chest pain from myocardial hypoperfusion, headache, fatigue, confusion, difficulty concentrating, and blurring of vision. At times, they will have this coat hanger headaches that present with neck pain due to hypoperfusion of the trapezius and the shoulder girdle muscles. And lastly, the most significant symptom that they can have is a syncope. So what are the causes of postural hypertension? We usually divide them into neurogenic causes and non-neurogenic causes. So neurogenic causes will be that of autonomic failure, and the non-neurogenic causes will be hypovolemia, cardiovascular disease, medications, and hypoadrenalism. At times, even despite optimizing all these, it may be an idiopathic cause that we can't identify. Hence, it's important to look through all these causes and optimize them to prevent postural hypertension. Now, I'd like to hand over to Dr. Tan to take you through how rheumatic diseases lead to falls. Dr. Tan, please.
Thank you, Dr. Ng. Now we will look through how rheumatic diseases leads to falls in various ways. Firstly, musculoskeletal disorders such as arthritis and fractures can lead to falls. Neurological disorders such as myositis, peripheral neuropathy, or mononeuritis multiplex can also lead to falls. Next, cardiovascular disorders such as pulmonary hypertension leading to heart failure can also lead to falls. Pulmonary disorders such as interstitial lung disease can cause falls as well. Other reasons such as impaired vision due to recurrent uveitis, pain from arthritis, associated depression in rheumatic diseases, deconditioning due to prolonged state of arthritis or myositis, or medications used to treat rheumatic diseases can also contribute to falls. Let's look at how arthritis leads to falls in more detail. Arthralgia or arthritis leads to avoidance of movement of affected joints. This then causes functional limitation and reduction of physical activity. This leads to muscle wasting around the affected joint, and therefore the patient can get general physical conditioning, which then leads to falls. Gait and balance disorders can also lead to falls. Gait disorders due to arthritis can lead to instability. An example would be a patient with osteoarthritis of the hip unilaterally and then developing Trendelenburg's gait on one side. The instability leads to the patient having a fall. Balance disorders due to arthritis, such as reduction in the joint flexion and extension range of movement due to pain, or joint deformity or muscle weakness as a result of arthritis, can lead to poor balance control, thereby contributing to falls. There are also associated sequelae of arthritis that can also further contribute to falls. Arthritis can have neurological sequelae, such as peripheral nerve entrapment causing foot drop, or central myelopathy, such as lumbar stenosis or cervical myelopathy, or motor weakness or sensory loss. These reasons can lead to falls. Psychological sequelae of arthritis, such as depression, is also a risk factor for falls. An index fall may then lead to further falls. Next, we shall examine how medication leads to falls by Dr. Ng.
So polypharmacy has been shown to increase fall risk, simply because medications can affect the maintenance of adequate blood perfusion of the organs that contribute to the optimal function of sensory and musculoskeletal system during postural change. As we see here, the antihypertensives, diuretics, tricyclic antidepressants, and anticholinergics can cause postural hypertension and trigger falls. Other medications, as listed here, antipsychotics, antihistamine, anticonvulsives, hypoglycemics, anti-Parkinsonism medications, and sedatives can cause drowsiness, affecting the individual's mentation to maintain adequate postural control. Hence, medications are a very high risk of falls and should be reviewed regularly. Next, we'll be looking at how to assess a patient with falls based on the multifactorial fall risk assessment tool. First, we need to identify the falls history to better understand the mechanism of falls, and then followed by the assessment of gait, balance, and mobility for muscle weakness, the patient's functional ability, and any fear related to falling, cardiovascular examination, medication review, for any visual impairment, looking at cognitive impairment and neurological examination, assess for any urinary incontinence and home hazards if falls are mainly occurring at home, as well as osteoporosis to prevent fracture in the case of a patient with recurrent falls. So let's look into how to approach falls by taking a focus history. So we want to understand the circumstances of falls, firstly to know whether there's any loss of consciousness. If there is no loss of consciousness, we will go down this algorithm of recurrent falls to actually take the history to identify the falls using this acronym SPLET. So when we fall, we make a sound, and I felt that this acronym will allow you, it's an easy way to remember. So firstly, S for SPLET, S for symptoms surrounding the falls, to find out whether there are any symptoms of dizziness, chest pain, breathlessness, any recent intercurrent illness, any tremors that they had any symptoms of incontinence and weakness, a numbness that they had before or during the falls. Next, looking at P, previous falls. Have they had any previous falls, especially falls over the last 12 months? Based on the previous falls and the history from them, to see whether the falls are pretty similar among the others. Looking at the location of falls to identify whether the falls is indoor, in the house, or in the community will give us a better understanding of the patient's frailty status as well. The activity of fall during falls is also important to determine whether what triggered the loss of balance. Were they bending down, stretching, reaching out for something higher, and therefore they lost their balance? Or were they multitasking? And perhaps there's possible signs of one will need to look into greater evaluation of their impaired dual tasking, if any, that may trigger the fall. The time of fall is important as well, day versus night, to determine whether possible visual impairments contributing to the falls will give us some clue from that, if we know the time, day versus night. And trauma from falls is also important to identify injuries and long lie. Subsequently, to identify for any presence of gait instability that requires walking aids, to look into the general medical history, acute and chronic conditions that may contribute to the fall, medication review, as earlier mentioned, environmental assessment is also important. Moving on to the examination findings, looking at the vital signs, the head and neck region, the vision, hearing, vestibular system, the heart, the neurological evaluation of the cognition, any focal deficits, tone, reflexes, signs of Parkinsonism, cerebellar function, and gait and balance. And also the musculoskeletal system, as earlier mentioned on by Dr. Tan. And lastly, the functional assessment is just as important to assess for mobility, the ADLs, activities of daily living, and continence. So let's look a bit more into the functional mobility assessment tools. So we want to assess the gait, the strength, and the balance when we talk about falls. So with gait, we want to look at the time up and go test. It's a quantitative test which is timed, and the subject is supposed to rise from a chair, walk 3 meters, turn around, and walk back and sit down. With that, we could assess also whether walking aids is required. And usually, if the individual takes more than 14 seconds, it actually indicates impaired balance. Other tests, qualitative, is looking at strength as well. Based on attempts required to get up from a chair, and if there's a need to actually push up with your hands to apply more steadiness upon first standing and upon returning. And lastly, also the gait speed is a 6-minute walk test at a normal walking speed, where if they take more than 6 seconds, that's actually signs of increased fall risk. And lastly, with regards to balance, we're looking at the Birch balance scale, which is normally done by the physiotherapist. After functional mobility assessment, we'll be looking into the laboratory and diagnostic tests. So it really depends on the history and examination findings on what needs to be evaluated further. But in all cases, because calcium and vitamin D is essential for bone health, and for fall prevention, if there's deficits, it should be checked. Other things are like cognitive function. If there's suspicion of cognitive decline, then B12, folate, and thyroid function should be checked. If there's suspicion of a cardiac problem, the ECG should be done, or even a Holter if there's a loss of consciousness. If there's murmur present, then echo should be done. And if there's a fall with head injury or suspicion of a stroke with presence of focal neurological deficits, CT brain scan should be done as well. Now, after having multifactorial assessment, we will move on to coming out with multifactorial intervention that's individualized and best delivered through multidisciplinary team approach. So we review the medications, ensure that to reduce psychotropics and sedatives, for vision assessment, to refer to the eye if the visual acuity is less than 6 out of 12, to treat any cardiovascular disorders, to refer for physiotherapy, to actually target strength, balance training, and advise on appropriate walking aids, to refer to the occupational therapist for home visits and home environmental modifications for fall prevention. If most of the falls are occurring at home, to prevent future falls. Of course, next, to refer to review for any foot problems and footwear, and to advise accordingly. And of course, if there's vitamin D insufficiency, replacement is required. And of course, education on falls is also just as important. And lastly, to treat osteoporosis to prevent fragility fractures. Now I will hand over the time to Dr. Tan to go through the case scenario of a rheumatic patient with a fall.
Thank you, Dr. Ng. So we look at a 68-year-old female who has rheumatoid arthritis and complicated by multiple joint deformities. She had a history of vasculitis in the lower limbs causing peripheral neuropathy. As a result, she has been using a walking stick as a mobility aid. She also has cataracts since 10 years ago and has been taking steroids since she was 36 years old. Currently, she is admitted for pneumonia. Her vitals are stable and she does not require supplemental oxygen. On her second day of hospitalization, she got up around 9 p.m. to walk to the bathroom. She did not inform any nursing staff of her intention, and she did not bring her walking stick with her. Unfortunately, she sustained a fall and landed on her bottom. She did not lose consciousness nor sustain any fracture. Let's examine her risk factors which put her at risk of falls. Firstly, she has multiple joint deformities. The joint deformities in her hands are as listed: ulnar deviation, swan neck deformities, Z-thumb, pain and stiffness of hand joints. This causes her to have difficulty gripping her walking stick and then weaker upper limb support during walking. She has also joint deformities in her feet, such as hallux valgus, hammer toes, pes planus, splaying of the second and the third toes. There's also callus formation on her soles. These cause her to have difficulty fitting into footwear and therefore causes altered gait. Her previous rheumatoid vasculitis causing peripheral neuropathy has resulted in residual numbness and weakness. These also cause her to have an altered gait. The cataracts also causes her to have impaired vision. At 9 p.m., the environment in the ward was dim and she did not use her walking stick. She also had poor fitting shoes where she wore slippers in the hospital environment. We now examine the learning points from the clinical scenario. Dr. Ng will bring us through the learning points.
Thank you, Dr. Tan. So we want to assess the injury and the vital signs are important to ensure that the patient is stable. We want to relook at the falls history, understand the symptoms, any previous falls or history of falls, the location of this fall in patient, the activity and the time of falls, and any trauma. Subsequently, we want to identify the precipitating risk factors for the falls. Was there any acute medical problem? Was there any visual impairment in this patient? For delirium assessment, urinary problems, foot health and safe footwear, as well as presence of postural hypertension. After the assessment, we would like to implement multifactorial interventions to treat identified acute medical issues and precipitating causes. Firstly, to order relevant investigations and x-rays dependent on depending on what is being found during the physical examination, to review medications that the patient is on, to advise for fall precautions by nurses, to activate bed alarm devices, as well as to refer to the physiotherapists to assess gait strength balance, optimize the mobility, and prescribe appropriate walking aids to prevent future falls. We also want to refer to the occupational therapy to assess the ability of this individual to perform ADL safely and to provide further equipment if necessary to maintain independence. However, if deemed to be not safe, then the nursing will need to be informed and assistance is required. Lastly, to submit an incident report under the risk management system of this patient's falls so that more investigations can be done if necessary to prevent future inpatient falls. With that, we thank you for your attention. These are the references. Thank you.